Hi, this is Taylor Olness and Lauren Jacobson. We are both chemistry health science students with minors in public and global health. Our interest in public health stemmed from Dr. Ingebrigtsen's Intro to Public Health course, which we took our sophomore year. One office hour visit with the three of us has led us to Dr. E as our research advisor.
We will be discussing minority health disparities, my experience working in a Nebraska clinic during the COVID-19 pandemic provided a new lens for me to view the patient-physician interaction. The rural clinic, contracted by the Tyson Meat Packing Plant, served mainly Latinx and immigrant workers. As I observed patient-provider interactions at work, I learned a lot. Educating the patients and clearly communicating their medical instructions appeared to play a role in the patient's outcomes and compliance. The providers I worked with were fluent in Spanish, which isn't very common in our rural community, and their language proficiency was vital as they cared for a Spanish speaking patient base. Many patients would travel from nearby towns, despite having other medical facilities closer, to seek care from these bilingual providers. However, even with providers speaking in Spanish, many patients still misunderstood and didn't comply with secondary medical instructions and protocols. Additionally, my experiences sparked the question that providers may not be as well equipped to care for ethnic minorities, especially in rural settings.
As a woman soon pursuing a career as a physician in Nebraska, I thought exploring health disparities would enhance my understanding and ultimately my capacity as a Nebraska healthcare worker. I would see statistics about the abnormally high mortality rates in the United States compared to other high income countries and wanted to know why this was the case. While looking further into maternal mortality, I also found that marginalized groups in the United States also have unequal access to healthcare, even in Nebraska. This sparked my interest in finding provider perceptions on these big issues. With both of us interested in the big topic, minority health disparities, we decided to combine forces and approach this research together. Being able to collaborate with each other has brought new ideas, experiences, and perspectives into this study.
Now we will review what we found in the literature. In the literature, a few themes appear to contribute to health disparities in minority patient populations. Several studies pointed to health literacy as the key determinant of patient compliance. Language barriers, especially among minority groups in the United States, can lead to medical mistakes and misunderstandings. One source, Partita 2007, even found that language barriers allowed less opportunity for physicians to obtain a comprehensive patient history, relevant clinical information, or increase their emotional engagement in treatment. Trust between patient and providers can also be influenced by historical events such as the Tuskegee syphilis study and the civil rights movement. Increasing awareness of cross-cutting cultural and social issues may help physicians initiate different styles of communication across ethnic groups and improve patient-provider relationships and outcomes. Also, leaders with a social or cultural understanding of ethnic communities have a better chance to address that community's needs. Minority professionals are more likely to deliver care to minority populations by accommodating needs such as irregular work hours. Ultimately, diversity in leadership may help close the gap between health organizations and the minority communities being served. When evaluating health disparities within rural Latinx immigrant studies, Martyr et al. Found that health disparities may stem from lack of health insurance coverage, long work hours, limited English proficiency, and limited access to medical records and history. These findings were very consistent to my observations working at the clinic contracted by the Tyson pork plant. Interestingly, this source also noted that cultural perceptions of minority populations seeking medical care may also contribute to health disparities. Sometimes, it is more culturally emphasized to rely on family or religious support rather than seek professional treatment for health problems.
My literature review focused on maternal morbidity and mortality In the United States, maternal morbidity and mortality rates are abnormally high compared to other high-income countries. Factors thought to contribute to this rise in maternal morbidity and mortality include underlying socioeconomic disparities, a rise in maternal age, obesity rates, and rising cesarean delivery rates. In the United States, African American women are 3 to 4 times more likely to die due to pregnancy-related complications than white women. The lack of universal comprehensive medical care in the United States has led to a growing number of pregnant women with chronic medical conditions such as hypertension and diabetes, and untreated underlying medical conditions which contribute to the alarming morbidity rates. Determinants of health include 5 essential areas. These include social environment, biology and genetics, physical environment, individual behavior, and health service. African Americans are disproportionately disadvantaged among all 5 of these categories compared to non-African Americans. The goal is that we can lessen this gap in access through the promotion of health equity. Promotion can include things such as educating the general public through easy-to-understand pamphlets, interventions, and educating healthcare professionals about these disparities.
Before continuing, there are important terms to understand. These are health literacy and health equity. Health literacy is the degree to which individuals can find, understand, and use information and services to inform health-related decisions and actions for themselves and others.
And health equity is the circumstances in which every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential of social position or other socially determined circumstances.
There were a few questions raised by the literature. After reviewing the literature, we decided to focus on provider perspectives concerning disparities in the healthcare system, language barriers in healthcare, and maternal health concerns. These 3 items also became our 3 central themes for our study.
We decided to conduct a qualitative descriptive study based on these 3 questions. How do healthcare providers perceive health disparities in our system? Does a lack of provider language proficiency pose a barrier to equitable health? And how might disparities impact maternal health outcomes?
For our methods, we conducted a survey interview-based study. Each provider had the option to participate via live interview or written responses. Most responses were ranked on a Likert scale, but we also gave the opportunity for further discussion or clarification of answers through 2 open-ended questions at the end of the survey. Our study was not hypothesis-driven, as the purpose was to gather information about provider perception.
Our survey was developed with relevant modifications of studies from Bridget Henn and the Kaiser Family Foundation. The Kaiser survey had been validated on a national scale. The survey used mixed methods approach consisting of 9 questions in total, with all but 1 question containing multiple parts. There were 7 closed-ended questions using variable Likert scales and 2 optional open-ended questions to allow for further discussion. There were also 2 questions which focused on language and maternal health disparities. We started collecting data on January 11, 2021, following approval by Wayne State College HSIRB. Data collection concluded on March 31, 2021.
Any Nebraska healthcare provider between the ages of 30 and 70 in a rural or urban Nebraska community who is currently practicing in any specialty was eligible to complete our survey. Although, we did obtain IRB approval to admit one 28-year-old into our study. A rural area was defined as a population less than 30,000 people, and an urban area was defined as a population greater than 100,000 people.
Participants were recruited through convenience sampling selected from medical practices in area communities or because they were personally known by the research advisor, Dr. Ingebrigtsen, or researchers' contacts.
Each participant was contacted by email, where each provider could choose to participate in the survey via Zoom or written responses, or choose to decline. The providers who chose to participate received an official survey with a consent form. The consent form was obtained from each participant. Participants were able to fill out the survey at any time convenient for them or during a mutually agreed upon time for both parties to conduct a Zoom interview, which was recorded for transcription upon completion.
Now we're on to our results. The demographic breakdown of healthcare providers was we had 9 total respondents between the ages of 28 and 49. We had 4 female and 5 male providers. We also had 4 providers who practiced in an urban setting and 5 in a rural. We also had 2 Hispanic providers and 7 providers white or Caucasian. 3 providers were proficient in a secondary language, and 5 providers had less than 5 years of experience in the field, and 4 had over 10 years of practice. Overall, it was a nearly representative sample size. It was difficult to recruit healthcare providers this spring due to the COVID-19 pandemic, especially since these providers were already often overstretched. Table 1 summarizes provider perceptions that provider assumptions are reasons for unfair treatment in healthcare. Providers were asked if they felt the healthcare system treats people of minority groups differently because some providers assume that people from minority groups may not have enough insurance or money to pay for the care they get. Possible answers were major reason, minor reason, or not a reason. While only 3 providers had second language proficiency, all of them answered that provider assumptions were either a major reason or minor reason for unfair treatment, whereas 5 of the 6 providers without language proficiency felt it was not a reason or a minor reason. Urban providers were split, 2 perceiving provider assumptions as not a reason, and 2 with the opinion that provider assumptions play a significant role in the treatment of patients. All 5 rural providers believed that provider assumption about whether minority patients have insurance was a major or minor reason as to why the healthcare system treats people differently. Provider gender may also be a factor, as females were more likely to express assumption, playing a larger role than males. Years of experience may also be a factor, as providers with less than 5 years of experience were more likely to answer that provider assumption of insurance coverage was a major reason than providers with more than 10 years of experience. Based on our results, rural female providers with less than 5 years of experience may have a heightened awareness on the impact of provider assumption. In addition to perspectives on provider assumptions, the 3 subjects fluent in a second language were also more likely to perceive biased treatment of non-white patients. All 3 subjects agreed that language, education, and ethnicity of the patient impacted provider perceptions. Most notably, these subjects, as compared to providers with no secondary language proficiency, were more likely to view communication skills as a major reason that patients receive inequitable healthcare.
Table 2 summarizes provider perceptions of patients' ethnicity on compliance. Providers were asked if they believed non-Hispanic patients were more likely to follow medical instructions and adhere to medications compared to Hispanic patients. Possible responses were agree, disagree, or no answer. This question aimed to gather provider perceptions on ethnicity as a determinant of compliance. Only 2 of the 9 providers agreed with the statement that non-Hispanic patients were more compliant than Hispanic patients. These providers happened to be male, rural, and had a second language proficiency. Meanwhile, females and providers in urban practice and those without language proficiency were most likely to disagree that non-Hispanics were more compliant than Hispanic patients. Providers with proficiency in a second language were more likely to perceive Hispanic patients as less compliant, while providers without language proficiency unanimously disagreed that Hispanic patients were less compliant than non-Hispanic patients. This is an interesting finding and may suggest that providers with a secondary language proficiency understand and develop closer connections with their patients. This survey found that male providers and those with a secondary language proficiency were more likely to perceive Hispanic patients as less compliant than non-Hispanic patients. In Table 3, it examined perception on health disparities among ethnic groups seen in rural compared to urban areas. Providers were asked if health disparities between ethnic groups in rural communities were more likely than urban communities. 6 of the 9 providers agreed that there are greater racial or ethnic health disparities in rural areas compared to urban areas. The 4 female providers unanimously agreed that ethnic groups in rural settings experience more health disparities, while males were split. The 5 providers with less than 5 years of experience were also unanimous in their agreement that ethnic minorities experience more health disparities in rural compared to urban areas, while those with more than 10 years of experience were divided. The provider's location and provider language proficiency made no difference in the responses, but the provider's gender and years of experiences may have impacted the responses. In general, the provider's years and their gender seem to have the strongest impact on perceptions and health disparities.
Table 4 summarizes provider perceptions of maternal health disparity patterns among minority populations, specifically among African American women. To assess this, providers were asked whether they agree or disagree to a statement asking if African American women were just as likely to receive specialized medical procedures and surgery in childbirth. The majority of providers believe that maternal care is equitable between African American and Caucasian women. However, more male than female providers agreed with this statement, perceiving that access to treatments are equal among the African American and Caucasian populations. Females were more likely to perceive racial disparities in maternal care, with half of female providers disagreeing that African American women got equivalent care as Caucasian women. Other factors, such as provider location, language proficiency, and years of experience, seem to have no notable differences in perceptions of inequitable maternal care by ethnicity.
Overall, we found greater differences between provider gender and secondary language proficiency. Also, there were more perceived health disparities in rural communities compared to urban communities. Future research with larger sample sizes is needed to determine any additional generalizable relationships.
Looking back on our study, one limitation may have been that surveys also lack an anonymous aspect, which may have caused respondents to answer less transparently. This lack of guaranteed namelessness also allows for risk of research bias, especially since contacts were known personally to us. One of our survey questions was also too specific. The intent was to assess provider opinion about African American maternal mortality rates, but we did not obtain this information due to throwing it out. Our sample size was also very small. Connections including the Nebraska Academy of Family Physicians and the University of Nebraska Medical Center fell through. Many providers and contacts were already overstretched due to COVID-19 and vaccine distribution. Our study was also conceived in pre-COVID times. Even though the Kaiser Foundation survey had been validated on a national level, we found that revising questions to be more relevant to our study would have been beneficial.
Future research may want to investigate the role empathy plays on provider perceptions. Perhaps, females are more naturally empathetic compared to their male counterparts. The role empathy plays in a female provider's patient-physician interactions presents as a probable reason they were more likely to perceive health disparities. Providers with secondary language proficiency can communicate more effectively with non-English patients, or at least empathize with the challenges associated with language barriers. Health providers able to directly communicate with patients of different racial backgrounds may empathize and relate with those patients better than providers without a secondary language proficiency. Empathy may also explain why providers with a secondary language proficiency were more likely to perceive biased treatment of non-white patients and contribute communication skills as a major reason that patients receive unequal health care. A larger sample size will help make more confident conclusions. The small sample size of this study prevents any statistical analysis or conclusions of causal relationships between the variables. Therefore, future studies may want to use a larger sample size to make more direct relationships between the variables. Additionally, it may be interesting to conduct the same survey among the general public. Then, we could see whether the general public perceives the healthcare system as more biased toward minority groups. The data could be compared against the provider's own perceptions on minority healthcare disparities.
And then here are our references. And we wanted to say thank you to all of the providers who took the time out of their busy schedule in the middle of a historical global pandemic to participate in our survey and talk with us about controversial topics in the medical field. We understand these are busy times and appreciate your time and input. Also, we would like to give a huge thank you to Dr. E for all of her guidance and time she has put into each of us. It has been incredible to work with one of our role models, and we could not have done this without her guidance.
Now, we would like to say thank you all so much for listening to this presentation. If you have any questions or comments, you can contact us via the emails on the screen. We appreciate your time.